Hi, everybody. So today we're going to be discussing pediatric feeding disorders. So what is a pediatric feeding disorder? It's a disturbance in oral intake of nutrients inappropriate for age, and it lasts about 2 weeks, and it is associated with one or more of the following: medical dysfunction, nutritional dysfunction, feeding skill dysfunction, psychosocial dysfunction, and inappropriate caregiver management of feeding.
So, some examples of children who present with pediatric feeding disorder. They have been observed in children with autism, developmental delays, and sensory aversion difficulties. So, autism spectrum disorder is a neurodevelopmental disorder characterized by repetitive, restricted, and inflexible patterns of behavior, interests, and activities, as well as difficulties in social interaction and social communication. Developmental delays are when a child falls behind in one or more areas compared to their peers, and sensory aversion. So there can be hypersensitivities, which is an overreaction to sensory input. So they can have heightened sensitivities to certain smells, tastes, or textures. And there can be hyposensitivities, where there's an under responsiveness to sensory input. So they would have a decreased sensitivity to certain tastes, smells, or textures.
Autism spectrum disorder and feeding. So, children with autism may display the following feeding behaviors: picky eating, limited independent feeding, a need for increased feeding times, and highly restrictive food repertoire. Children with autism often have a preference for certain types of food based on taste, texture, color, or temperature, and this can impact their overall weight. And then children with autism can present with problematic behaviors such as yelling, not sitting at the table, and aggression, and also those tantrums.
So, what are some signs of pediatric feeding disorders? Arching back when feeding, turning their head away from food, vomiting, breathing difficulties with feeding, coughing and or choking during or after swallowing, crying during mealtimes, difficulty chewing textures that are age appropriate, gagging on food, taking a long time to finish meals or snacks, and losing weight or having trouble gaining weight.
So, some screening that we can use, these are assessments that can include parent surveys and screenings with the SLP. So, this can include the CHOMPS assessment, which is designed to evaluate eating and related skills, offering insights into various aspects such as textures, utensils, beverages, and other oral motor preferences. We can also use the sensory systems checklist, which is designed to identify a child's sensory preferences, sensitivities, and any other challenges they may encounter. And then we can also use the impact of feeding on parent and family skills along with the FAM-FEED, which is designed to assess how a child's feeding affects their parents or their family, as well as how the family addresses these feeding and associated challenges.
So now we are going to talk about a case with pediatric feeding disorder, and this one is about Brad. So Brad is 2.5 years old. He has sensory aversion, so he only eats pureed foods and he only likes liquids and purees at room temperature, so nothing that's too hot or too cold. He has a diagnosis of autism. He prefers finger foods and he prefers to be fed by an adult. The parents said that their goal is for their child to use a utensil such as a spoon when eating independently. Using a textured spoon will help when introducing new textures to him, as well as promoting his independence during feeding, and this aids in his overall feeding skills. He currently exhibits extreme food selectivity, accepting only smooth purees and avoiding any foods with texture. His sensory sensitivities are pronounced, particularly regarding food textures and tactile input, such as avoiding sticky substances and walking barefoot. And Brad demonstrates limited verbal communication and reduced joint attention, often relying on finger feeding.
So, the relation to the pediatric feeding disorder. So, Brad has the diagnosis of autism, and that research has shown that approximately 62% of children with autism will present with feeding difficulties, including increased food selectivity, greater likelihood of unhealthy eating habits, and associated mealtime related behavioral problems. So Brad demonstrates with a pediatric feeding disorder as evidenced by his sensory aversions due to his psychosocial dysfunction. Brad only eats pureed foods and does not independently use utensils. So, a goal for feeding therapy with this child would be to tolerate being around soft mashed table foods, such as an avocado mash. Then we would want him to tolerate the smell, and then finally touching it to his mouth. So, all of these steps are crucial in order to eventually get him to eating the food.
So now we're going to talk about some treatment options. So one treatment option could be using different equipment during feeding, such as a textured spoon. This is for individuals who have difficulty with certain textures, like Brad with sensory aversions, individuals who are transitioning from pureed to textured foods, individuals who have difficulty with larger boluses, and individuals who have difficulty removing material from the spoon.
So, why is this useful? It aids in the introduction of new foods and textures. It encourages independence during feeding while also aiding in overall feeding skills. It increases overall sensory awareness and increased oral sensory stimulation to the lips and tongues, which provides the tactile input during feeding.
So another treatment option is to discuss what the child's developmental hierarchy is with the team. So what is the developmental food hierarchy? It is an arrangement of food items that gives a breakdown of when and what types of foods to introduce to the children. This is a gradual process of foods that we introduce to the children, and it uses this hierarchy to determine what the next step is for your child when you're introducing foods.
So, other treatment options are working with the SLP to determine a developmentally appropriate texture to focus on. So, like soft mashed table foods, for example, that avocado mash. This is the next step of food texture that we'd want to target with this particular child. We want to make sure we introduce this gradually, and we also want to make sure that we make mealtime positive and also fun. And lastly, we don't want to force the child if they don't want to touch, smell, or taste.
So this is the developmental food hierarchy with some examples, and all of them on the left. So the breast in the bottle, the thin baby food cereals, and then the purees are all steps in the hierarchy that Brad has met. So now on the right-hand side, we would start with the soft mash table foods, and the table food smooth purees, like the avocado mash. So this is kind of just showing you the steps that you need to meet, and then it tells you where you would leave off with working on a new texture.
So, some counseling for parents, we want to make sure that they know that those sensory aversions are normal. Number two, we want to create a positive mealtime environment. Number three, food exposure. So, we want to gradually introduce these new foods. Number four, don't force it. If a child doesn't want to smell, touch, taste, don't make them. Um, We also want to make sure that it's a fun experience for them. So, number five, that food play, make fun eating. And then lastly, number six, model. So, smell your food and make an audible noise like, yum, that smells so good.
Okay, so some more counseling for parents. We want to make the setting playful, nurturing, and non-threatening. So you can do things like play hot potato, make cookbooks, or make a recipe. You can also use peers or siblings for support, but remember, if they don't want to touch it, don't make them touch it. Our goal is for the child to lead the activities and enjoy learning about new foods. You can also try role reversal. So you can allow the child to feed the adult, allow the child to bring the food to your nose, and we want the child to know that we are all in this together. And at the end, we want you to maintain a positive attitude overall.
So, now what can you do at home? You want to make this mealtime setting playful, nurturing, and non threatening. So you want to incorporate things that the child enjoys. So we're introducing him to like the new textures and foods and also taste. For example, if your child likes Bluey, we want to try to incorporate Bluey into the feeding, maybe with a Bluey stuffed animal or a video of Bluey. We want to model. He will learn so many things from your continued modeling. Use peers, staff, siblings for support. And remember that our overall goal is for the child to lead the activities and enjoy learning about new foods. This isn't going to happen overnight and it's a gradual process. So we want to ensure that the parent and also maybe like the team is patient with us. Try role reversal. Allow the child to feed the adult, allow the child to bring the food to your nose. And this message to the child is that we're all in this together and overall maintain that positive attitude.
So, how can you help their hydration with pediatric feeding disorders? You can recognize signs when a child is dehydrated. So, these can be things like dry mouth and lips, if they're cranky or irritable, tired or lethargic, and if they have rapid breathing. You can also establish a routine for hydrating, similar to when babies are feeding. So, you can give them water every couple hours. If your child is an infant under 1 year old, you can contact their pediatrician to discuss the best way to rehydrate them.
Now, when to seek support for hydration. So, if a child isn't drinking anything for over a few hours, there's signs of dehydration and that hasn't gotten better. So, this is dry mouth, less wet diapers, rapid breathing. Vomit is bright green, red, or brown. And they haven't started eating food in about 3 days.
So, how can you help their nutrition? You can create a fun environment for feeding to encourage the child to eat and participate. So, you can do things like playing a game or using a fun cup or plate that you know the child likes. You can talk with the team, like the pediatrician, the SLP, and the nutritionist, in order to determine if nutritional supplementation is appropriate for the child. You can also be patient when introducing new foods and maximize on the foods that the child does like for nutrition.
So, when seeking further assistance, we want to contact and meet with the team, which includes the SLP, nutritionist, primary care physician, occupational therapist, and gastroenterologist.
So, what can a speech language pathologist do to help your child? They can help make the muscles of their mouth stronger, help move their tongue more, help chew foods, help try new foods or drinks, improving how they suck from a bottle or drink from a cup, helping babies learn how to breathe when sucking and swallowing, changing food textures and liquid thickness to help swallow safely, addressing sensory issues, and changing the positioning of feedings.